Thank you very much to Ellie and everybody involved in the Leg Club to allow me to be part of this prestigious event. It's an honour to be here. I was here at the workshops last year and I'm very sorry that I couldn't be here yesterday because I bet it was fantastic. So once again, somebody mentioned earlier, I think it was Jackie, that Ellie gives you these titles and then you sort of heart sinks for a moment where you think, how on earth am I going to answer that? And I was given the title of, is it chronic edema or lymphedema? Okay. I'm going to try. Whether we'll actually get anywhere or not will be your guess, will be as good as mine. But we all know what we think they both are and what we see. We saw some images earlier of some very complex large wounds, but these are some of the patients that we see in clinic with upper and lower limb swelling and some of the words that they use to describe their swelling. And I think that it is a growing problem and something that we are all facing a challenge of dealing with. So whatever we're going to term it, and we've heard the importance of assessment and history taking in order to ascertain a diagnosis, we just need to be able to help people. It's the most important thing. So we're going to whiz through the anatomy and physiology of the lymphatics. We're going to try and explain some of the terms that you'll hear bandied around, try and aid you to recognise what type of swelling it is, how we might then implement some treatment, and I'm going to mention some of the tests that you can do in your clinics and in patients' homes, and also the tests that may be more specific, may need hospital treatment. So quick review of the lymphatic system. There's a deep system and a superficial system. Your deep system is made up of your lymph nodes, the spleen and other large ducts, and then the superficial system is a network of tens of thousands of tiny little lymphatics, which are the width of a human hair, so not visible to the naked eye. That's why we dye them to see them in theatre. Those initial lymphatics are like the villi within the intestine. They're finger-like little blind-ended vessels, and they have endothelial cells which are attached to anchoring filaments. And when we move, this pink shaded area is supposed to be a muscle. As we move, the anchoring filaments move, allowing the endothelial cells to open and fluid to enter those initial lymphatics. The deeper system, so once we go down from those finger-like projections into the vessels below, they have muscle within them. They are able to move with a peristaltic motion, which is influenced by breathing and movement. And they have a series of one-way valves. They are called lymphangions, and together they look like a beaded chain. Don't look like that because I've drawn that, but they do look like that. And the lymphatic system rejoins the blood circulatory system high up in the chest. So you can see that on the left side, that's from the thoracic duct, and on the right side, that's from the right lymphatic duct. So when patients say, where does all the fluid go, nurse? We can actually explain that it goes back into their circulatory system and they will eventually wee it out. But we're talking about very small amounts, so they're not going to be running to the toilet. So the original question, is it chronic edema or is it lymphedema? Chronic edema is a term which encompasses all types of swelling that's been present for 3 months or longer, and that includes lymphedema. There has been a real sway in the thought about chronic edema over the last few years, and that really was the fact that for many, many years we believed the Starling equation to be true, that 90% of fluid was returned via the vein network and 10% was left behind for the lymphatic system to deal with. Have any of you heard that before? The 90 and 10. Well, we know that that's not true. We've now found that actually all fluid is returned from the interstitium by the lymphatics, and therefore we understand why it's so much more of an important factor in patients with chronic edema than we perhaps thought it was before. And I've said there that all edemas are lymphatic, which is true. However, not all edemas are lymphedema. And we're going to break them down into the different sections now. But how big a problem is it? Well, we know that there are approximately 500 million people worldwide with lymphedema for various causes. And is that true lymphedema or chronic edema? We don't know. that's not been broken down. We know that in 2012, Christine Moffat did some work around Derby and Nottingham and showed that 3.99 per thousand in the UK population have chronic edema, which increases to 10.31 and then increases again to 28.57. So massive increase with age, which we know because the vast majority of patients we see with chronic edema are in the older category. But those numbers are very similar to leg ulcers and actually much higher than VTE. So what else do we know? We know that there are probably close to 65,000 people living with true lymphedema after cancer treatment. And that mentions three types of cancer: breast cancer, pelvic, encompasses quite a few, including gynae and urology, head and neck, but it doesn't mention the other cancers that we see regularly, for example, malignant melanoma. The vast majority of patients with melanoma will have groin node or axillary node dissection, and a massive proportion of those go on to get lymphedema. So that's an underestimation in our opinion. In our trust, we did a snapshot audit as part of our leg ulceration pathway. We knew that the patients came into hospital, had everything stripped off them, all of your hard work undone in the vast majority of cases, because nobody within the trust now is able to apply compression bandaging. There are no dressings available on the wards anymore. Nobody recognises any problems other than decubitus ulcers. They seem to be the only thing that has any bearing in the trust. And then the patient will be discharged, either back at square one or potentially worse with their lower limb condition. So we did a snapshot audit. We just wanted to know how many people had got a lower limb wound in the hospital without a dressing or a bandage on. And we found that 60% of patients had a lower limb wound. I think that's quite shocking, really, when you think that none of those patients were actually getting care for that wound. They were in with some other acute problem. And although we can say the average length of stay, certainly within my hospital, is hours now, never mind days, there are patients who are in for 2 or 3 weeks still with complex problems, and what happens to their lower limb wounds? So it's something that we've raised, and we've managed to come up with some new ways of working, but that's little to do with what I'm talking about today. I just wanted to share it with you. And I'd like you to think about your own areas, your leg clubs, your areas where you work. We talked about nursing and residential homes earlier, inpatients' homes, wherever you encounter your patients, to think about doing a Stemis test. Now, this is one of those easy, quick tests I was saying about that any of you can do. So a Stemis test is whether you can lift a fold of skin at the base of the second digit. So that could be in the hands or in the feet. And if you can't lift a fold of skin, then it is positive. If you imagine going round your average area where we would see patients, for me, maybe within a ward setting or within a nursing home, and actually performing that test on everybody there, I think we'd probably not be surprised to think about 80 to 90% of those patients have probably got chronic swelling, and yet I doubt any of them would be receiving any treatment for it. So who is actually at risk? Well, essentially anybody with a known underlying genetic pathway, anybody who has any form of malignancy, and especially so if they have surgery or radiotherapy, anybody with chronic venous insufficiency or immobile patients in any way, shape or form, be that just a limb, for example, after CVA, or be it due to a congenital condition like spina bifida. Filariasis is the biggest cause of lymphedema worldwide. That's a bacterial infection which is from a mosquito larva. We don't see huge numbers of cases in the UK, more within the capital city, where we perhaps have a greater number of people coming into the city from abroad, but it certainly is the biggest cause of scrotal and genital edema worldwide. Anybody who suffers trauma to the lymph nodes or vessels, that could be anything from a sprained ankle where the ankle swells quickly but then the swelling doesn't resolve, and anybody with chronic skin disorder, psoriasis, eczema, anything that causes that continual fit and flare with inflammation. So these were the headings we said we'd try and break down. These are the different types of chronic swelling. We've got venous edema, dependency edema, lymphedema, as we said, infection, Lipoedema, and edema in advancing disease. And although they overlap, we should try to pull out which one it is, because that does help us, as we've heard earlier, to direct patients to the correct treatment and to get them involved in their own self-management. And some of the other terms that you might know these things as are also listed there. So, lymphedema. First, because it's my baby, it's the most important thing for me, but because it's probably the most difficult and the one that we get everybody lumped under the same heading as. So it's due to inadequate lymphatic drainage where the lymphatics cannot absorb that fluid, but there is normal capillary filtration, so not an excess of fluid. There is a high protein concentration. We talk about high protein edemas where the lymphatics transport large protein molecules and are not able to evacuate those when there's a problem with that drainage system, and therefore the fluid within the limb is very rich in protein. But there is a normal lymph load, again as we've said, normal capillary filtration, normal lymph load. There is not an excess of fluid within the body, so diuretics would not help. It can affect any part of the body, anywhere at all, an earlobe, a breast, a foot, a toe, a finger, anywhere. And we do see patients with isolated swelling within a small area. Patient history will usually help us to determine the cause, whether it's primary or secondary, which we're going to look at. For example, the example is given there of a patient who'd undergone lymph node removal, so you'd already be starting to think down that route as to the cause. The types of primary lymphedema are congenital, so present at birth or within the first 2 years. And this could be due to absence of the lymphatics, underdeveloped lymphatics or small lymphatics. Opposite, mega lymphatics or leaky lymphatics with leaky valves. Valves within the lymphangion I showed you where it was supposed to be beaded. Those valves can leak just like they can in venous disease. The hereditary genetic process we've started to learn a lot more about. We've certainly grown our knowledge and the number of genes that have been identified over the last 5 years has gone from approximately 5 or 6 genes to over 20 genes. So we're constantly learning much more about it. And this is the chart that we've developed with St George's Hospital in Tooting, South London, as part of our Children with Lymphoedema Special Interest Group, so that we are able to work through a flow diagram to ascertain why the children we see do have swelling. It's often the case they have a syndrome rather than a standalone reason for their swelling, so we need to be careful to exclude all those things and have to work very closely with our paediatric colleagues. But you can see in red there, I'm not going through this, but you can see in red there the identified genes that we've got, and all patients it's recommended that they are seen at specialist centres to ensure that genetic testing can be done for their families and their future families. This is a lady with primary lymphedema. She developed her swelling age 18 and she was told that it was because she'd gone on the contraceptive pill. Clearly that isn't the case, or anybody that went on the contraceptive pill should be developing leg swelling. This was nothing to do with a blood clot because of that. It literally started out of the blue. She woke up one morning with lower limb edema. She's a primary school teacher, so couldn't bend to sit on the tiny little chairs. And what you can't see so much is that on this side you can see there's a sheer panel to her underwear. On the other side you can't see it, and that's because of the doming of the leg. It was so significantly swollen throughout. Primary lymphedema is predominantly a female condition, about 87% female. Another thing for us to cope with, sorry to the lucky men in the audience, and often does start around hormonal burden time, so puberty and pregnancy being key. This is our youngest patient at the time. We've beaten it now, but he was born with swelling to the tops of his feet. You can see his little toes are very swollen. He's got genital edema as well, and he has an identifiable genetic primary lymphedema of Milroy's disease. And what was interesting in his case is normally with Milroy's, the whole family, you could draw a picture or take a photograph of the legs and you wouldn't know which member was which. But actually there wasn't any visible signs of swelling within the family, but there were carriers of the gene. Secondary lymphedema, the much more common lymphedema that we see. We've said about parasitic infection, filariasis, but the most common reason in the Western world is cancer and its treatments. Lots of post-infection as well, so lots of patients who have acute cellulitis, very surprised to then develop a lymphedema. This lady was run over by a bus when she was about 5, had loads of skin grafting, and this was in her early 20s when we saw her. She'd always managed particularly well with her scarring, always worn trousers, didn't have any problem with that, but started to develop swelling to her foot. And the one thing she wasn't going to be without was without the footwear of her choice. She never wore, in her opinion, the clothes of her choice with a scarring, but shoes, boots, sandals, stilettos were the types of shoes that she gave her femininity and her choice of fashion. And when her foot started to swell and she couldn't do that, that was when she sought help. And there was swelling throughout the scar as well, so we actually compressed the whole leg. Lymphedema does have its own set of problems, so it causes these skin changes over time. We've seen some evidence of hyperkeratosis earlier, the thickened brawny pigmentation, build-up of keratin, and also papillomatosis, the cobblestoning that we get. The tissues become thickened over time and don't reduce with elevation or diuretics, as we said. Positive Stemis sign, unsurprisingly. Shape can be normal to start with and then distort over time. We get lobuli and overhang of the legs. And as we've said about the high protein edema, these patients are massively at risk of cellulitis. So all our patients are given strict advice about how to prevent infection. Many of them, unfortunately, do still go on to get recurrent infections, and we need to use prophylactic antibiotics. And there is a fabulous consensus document available free for you on the homepage to download at the BLS.com. It's also on the LSN, the Lymphoedema Support Network's website, and it talks about how we manage infections in patients with swelling, what antibiotics we should use, and it's been done nationally with microbiology charities involved, so it's an excellent document. The swelling may not be limited to the limb in time. It may spread onto the trunk, and if there is no visible edema but feeling of tension, heaviness and tightness, this may be an indication, specifically in patients who've had lymph node removal, that they are developing a lymphedema, and we would actually instigate treatment at this early time. Swelling can, as I've said, affect only small areas rather than others, so don't be surprised if we have patients who only have one finger that's swollen or just the inner aspect of an ankle that's swollen. We would still treat the whole limb in an effort to get the best outcomes for the patients. This is a lady with secondary lymphedema, breast cancer-related lymphedema, lymph glands removed from the axilla, and then has gone on to develop arm swelling. You can see she's got Cabbage Patch Kid knuckles or toddler's knuckles where they indent, deepened skin folds around the wrist, around the elbow, and the arm is extremely heavy and uncomfortable, although it doesn't actually cause pain itself. This gentleman has secondary lymphedema again related to cancer. He's a cancer of the prostate patient, had extensive radiotherapy, and the limb is swollen from toe to groin, and the genitalia is also swollen and across the mons pubis. So we need to extend our treatment to the whole area that is affected, not just the limb. Otherwise, we run the risk of forcing fluid onto the truncal areas. So we're trying to keep in mind, is it lymphedema or chronic edema? How is lymphedema different to chronic edema? Well, it's not. As I've said, lymphedema is a chronic edema of itself. And then it is different because there is an underlying lymphatic pathology which we won't get in other types of edema. And then it's not because it responds to the same treatment options. And then it is because you can add in other treatment options that you wouldn't for chronic swelling. I was getting myself in more and more of a mess with this, as you can probably tell. Lymphovenous edema, phlebolymphodema, whatever you want to call it. We like phlebolymphodema because it means we blame the veins first. So the lymphatic bit only came after it was overloaded. We have increased capillary filtration, so extensive fluid leaking into the tissues, often due to essential hypertension. And then over time, that lymphatic system fails. It is something which is extremely common and massively undertreated. The huge plethora of venous insufficiency that can lead to it. There's a few of them listed there, thinking about PTS and varicose veins, but it essentially is anything at all. Lipodermatosclerosis we used to think was an indication of venous disease. If you read anything on signs and symptoms of venous disease, it will say lipodermatosclerosis, but actually what we're starting to understand within the lymphedema world is that actually this is probably much more a sign of lymphatic obstruction, because we get sclerosis of the tissue, narrowing and destruction, thickening, woody tissues, which is what we get in end-stage lymphedema. So it may well turn out that, once again, like the styling principle, the textbooks were not quite right. Hemosiderin staining, you'll all see that browny pigmentation under the skin when patients keep saying, will that go, will that go? And no, it won't go. And telangiectasia or thread veins are perhaps our first indicator and when we should act, but we don't. If we all wore compression hosiery like our continental colleagues do, most ladies in France, Spain and Germany will wear compression hosiery from puberty until, well, until old age, and they can no longer apply it, but certainly it prevents a vast majority of the lower limb problems that we get, whereas very few of us will actually purchase support tights or will support our lower limbs, and yet certainly within the nursing profession we spend a massive amount of time on our legs or kneeling, and probably are the people who should be protecting ourselves. Again, largely determined by the patient from questioning and history taking, but unlike lymphedema, starting with a lymphatic pathology, the venous pathology means that often there is more give within the tissues. Generally they are more pitting, and elevation will help, and in some circumstances diuretics do help, but that's only really in the early stages. As time progresses, then those things will no longer work and your intervention will be required. Restless leg syndrome is a massive problem in patients with swelling, and we think that's because the weight of the limb just aggravates their already compromised vascular system. There's been a couple of patients you've seen the pictures of there, but this gentleman has lymphovenous edema with following a CVA. He's got a hemiplegia, which doesn't help any of his problems. Redness throughout the limbs is actually bilateral, which we'll talk about, so it's not indicating a cellulitis, but the distortion of shape that he was getting from his swelling and the way that the leg pitted, so anything that he wore, socks, trousers, shoes, marked extensively, and was of great concern to himself and his wife. We talked about the skin changes you see in lymphedema, those in venous disease we've touched on, but we do see a significant amount of varicose eczema, which is often wrongly diagnosed as contact dermatitis or other problems, and varicose veins are rarely, we find, referred for surgery if they're symptomatic. There seems to be a belief that we've stopped doing surgery for varicose veins. That certainly has been the case for many years, but the NICE guidance and general Vascular Society guidance is that we should be referring any patients who are symptomatic with varicose veins with achy legs for surgery. It is the most appropriate intervention and can prevent long-term problems. Dependency edema, gravitational edema, armchair legs, they've all got tens of different names, but essentially it can be of a limb or because the whole system is dependent and immobile. We have a lymphatic overload over time, similar to lymphovenous edema, because of that excess capillary filtration due to lack of movement. We said the lymphatics are only influenced by deep breathing and movement, and if you take away one part of that, you've automatically got a risk factor. So any patient who is immobile, and it doesn't have to be completely immobile or paralysed, partial immobility due to age and debility, due to osteo or rheumatoid arthritis, CVA we've mentioned, the congenital conditions, there's many of them, but the vast majority of patients we see have spina bifida because they're wheelchair bound, don't move their limbs at all, great doming to the tops of the feet, often skin breakdown and pressure area damage as well. Can be abdominal, so we're seeing a significant increase in the number of bariatric patients we're caring for with a very large apron fold, and that becomes dependent and hangs and thus is at risk of dependent edema. I don't know if any of you are involved in management of skin breakdown in pendulous abdominal folds, but certainly it is a growing area where we are seeing massive amounts of time, energy and money needing to be spent. The skin's often quite shiny and thin, and again it has a very soft, squidgy texture to it, very similar to in edema in advancing disease. The skin and tissues in edema in advancing disease, it always alludes me to think about the patient in bed with a catheter, and when you pull the duvet or the covers back, the catheter tube has left a beautiful embedded mark in the leg. We've all seen that, or the leg bag, and again it's very soft pitting edema. Edema in advancing disease is very similar and has the same cause as dependency edema. However, whereas in dependency edema we can often massively improve that swelling, in edema in advancing disease, we can't always achieve that. Although we would still set out to provide active treatment, it may be that we can only palliate the symptoms. But certainly it may be due to lymphadenopathy, blockage of the lymphatics due to the tumour itself. We do see other types of malignancy like Kaposi sarcoma after in HIV positive patients who again it will eat away at the lymphatics, that causing that obstruction. Hyperproteinemia or low albumin levels in the blood is a big culprit of whole body dependency edema in advancing disease, and that's often seen in those end stage patients with failure. This is interesting, even though it's old now, from 1994. This was the Handbook of Palliative Care, Kay's work, and what he was looking at was the common symptoms that patients have and how good we are as healthcare professionals at dealing with them. And what's really interesting is that the same amount of patients, 60%, were suffering from dyspnea, insomnia and sweats. And yet I would argue that very few nurses have received any training on edema management or how to implement any care for that condition. And yet common things that are only 5% above that in constipation, that's something that most nurses would pride themselves on being able to know what to do, whereas edema management seems of much less importance, but certainly not so if you ask the patient. Most of them would love to be able to get their slippers or shoes on or wear some appropriate clothing other than tracksuit bottoms or adapted pyjama trousers. Another cause for secondary chronic edema is in inflammation or infection. We said about the chronic skin conditions, this constant inflammation causing that excess of leakage of fluid into the tissues, but also rheumatoid arthritis has a similar process, and fungal infections, people that have recurrent athlete's foot can develop a chronic edema. We would never think that athlete's foot could be responsible for overwhelming a lymphatic system and then it will fail and leave you with a permanent foot swelling. I don't think any of us would think of that. But when we dispel athlete's foot as being something and nothing, when that's in teenagers, certainly we've had a young guy who plays rugby near us who had recurrent athlete's foot, thought nothing of it, kept putting the powder on but didn't really address it. He has got a chronic swelling now which is never going to go away. He's able to manage it, but we wouldn't think that of athlete's foot, and other fungal infections act in a similar way. With cellulitis, that then causes a chronic infection. We don't know a chronic edema. We don't know which bit came first. It's quite chicken and egg. Did the patient have an underlying lymphatic pathology that we didn't know about, and then the cellulitis has overwhelmed the lymphatic system, and that swelling has become apparent? Or is it that the lymphatics were destroyed by the acute inflammatory episode in cellulitis and their swelling is thus permanent? We don't know which way round that is, and there's some work going on at the moment to see if we can pull that out a little bit. The one thing that is important is that we think about what's the difference between cellulitis and red legs, and I said I'd touch on that. The amount of patients that we see with cellulitis, the patient will tell you, oh, I've had 10 episodes of cellulitis this year, nurse. Have you? You've been in hospital? No. You had antibiotics a couple of times. Oh, you've done well. Did you feel unwell? No, I was fine. Okay. It's very, very unlikely that you've had an episode of cellulitis. Oh, no, I did. They told me. Who told you? The nurse and then the doctor. Right. And you can't unpick that. Once somebody's been told they've had something, there's no undoing it. But the important bit is that we get our diagnosis right, and we have talked about that a lot. So thinking about the difference between cellulitis and red legs. Red leg syndrome is something that is real. It is something that you can give patients a name. Everybody likes to have a name. What's wrong with me? Why are my legs red? You've got red leg syndrome. You haven't got acute cellulitis. If it is bilateral, it is never going to be cellulitis. That's the only thing we need to know, because I'm sure I can put my hand up. When I started in 1995 in a lymphedema clinic, we put patients on antibiotics when their legs were red because we thought that it was infected. It was hot, it was red, it was painful. They were complaining. You know, that was good enough for us. We stuck them on antibiotics. And that's what happens. And we feel sorry for people and we want to do the best by them. But actually we need to only be treating when it is an acute cellulitis. And the vast majority of those happen so quickly that the patients will end up in the emergency portal still, and they will need intravenous antibiotic therapy, which of course could be given at home if appropriate. Lipedema, hopefully not something that you'll come across regularly because the patients don't have wounds, but there may be occasion where they have developed a wound or have sustained a burn or some other thing that you'll come into contact with these patients with, but it is useful nevertheless for you to be able to see and recognise this condition. You may even know people with it. Lipedema is the irregular laying down of fat cells where they would not normally be, and it gives a shape, what we for years in the UK have called pear-shaped. That's if you're unlucky, you've got a large bottom and large thighs but a little top, you were pear-shaped, and that was seen as being acceptable. It's just your genetic makeup, get on with it. What we know is that actually some of those patients will have lipedema, which is a recognised condition. In 60% their venous system is insufficient and doesn't work effectively, but they do have, on lymphoscintigraphy, an investigation which we'll talk about in a second, they do have a normal lymphatic system, but sometimes it's a bit slow. So there's not parts of it missing, but sometimes it's a bit slow. And it is always bilateral, so it'll always affect the same on either side. It can affect all four limbs, so it can be the upper limbs as well. And it looks like a pair of jodhpurs on the lower limbs. So it looks like it comes from the waist, across the bottom, down to the ankles, but then it goes in at the ankle and the foot is perfectly normal. There is no swelling whatsoever. The tissues are very bouncy, so there's no pitting, no denting, they bounce you off them. And there are rarely any skin problems whatsoever, which is why these patients, because they're fit and healthy and work and don't have any issues, they often don't get picked up at all and struggle on themselves. They bruise very easily and their limbs are extremely tender. They can't bear anything to push on them or mark them or indent them. We don't know what the true cause is, but we think it's genetic. Woohoo! It's a women-only condition, yet again. It comes on at puberty, so again, the most important kind of development stage of your life, this shape starts to come. The important bit about it is that we shouldn't confuse it with obesity. And often it is. GPs will say, well, you just need to lose weight and that will improve. And we have patients who lose so much weight to try and improve the condition, you can actually see the veins across their abdomen. They've lost that much weight, but their top half is the only area that they manage to lose any weight from. Obesity causes chronic edema, which is completely reversible. So if any of you have seen some of the glorified titled programmes on TV, I ate my 10-ton burger or the 500-stone man or whatever these awful titles they come up with are, they'll all have chronic edema. Most of them, it's end stage, so it's a lymphedema. The lymphatic changes are apparent. You'll see the lobuli, you'll see the cobblestoning, hyperkeratosis. But when patients lose significant amount of weight, those symptoms completely reverse. So it's a bit like when they're diabetic, have bariatric surgery, no longer are diabetic or require any diabetic medication. The chronic edema is completely reversible. We've talked about edema within the apron fold. That, again, doesn't have to be dependent where it collects. Sometimes people have good tissue tone despite the fact that they're large, and that, again, can pose us significant problems with how we get that fluid out of that area. We do know that it's becoming more of an issue with infections because we're having to titrate our antibiotic therapy for larger patients, so we're having to work with microbiology to look at the prophylactic doses that we use because they're no longer effective. So, in order to try and find out whether it's lipedema, lymphedema, whether it's primary or secondary, whether it's dependency, whether it's lymphovenous edema, we need to think about our history taking. So you're all experts in taking history, interviewing patients, examining patients, and carrying out investigations. But when we're thinking about a patient presenting to you with chronic edema, this is the quick pathway that you need to go down to just exclude some of those things. First of all, the swelling should have been present for 3 months. If not, it's not a chronic edema. It's an acute edema, which is different. And I'm not even going to begin to go into that because that's a whole different ballgame. But if it's been present for 3 months, it is a chronic swelling. Then we should be looking at, have they had a history of cancer? Don't take that from any medical records because, believe you me, very often it's not in there. I get patients referred all the time and there's not a mention of anything in their medical notes within their GP records that comes with their referral or anything else. And that's because it may have been such a long time ago, it just isn't mentioned, or it may be that it was not thought of being important. So sometimes skin cancers that are non-metastatic are just disregarded, or Bowen's disease is not seen as being a malignant condition. All of these things are important because they may actually give us an indication as to what's going on. So whether they have a history of cancer or not, if they do have and have had a history of cancer, we should be looking at whether they are complaining of any of the symptoms other than the swelling. So if it's only the swelling, then we can plod along safely thinking this is probably a chronic swelling, maybe a true secondary lymphedema. But if it is that they're complaining of pain, tightness, reduced mobility, weight loss, fatigue, other symptoms, it could well be a recurrence of their disease, so we do need to be screening them. If they've never had a history of cancer, then we will take their full medical history as we would do for anything, perform our examination and investigations as necessary, and then try and ascertain which type of swelling they've got so that we can then move them on to a treatment plan. I'm not going through history in detail because it's what you do all the time, but medical, social and edema history, that might be the only bit that you don't do at the moment. So taking an edema history. When did the swelling start? Where did it start in the limb? Exactly where? Exactly when? Not, I've had it for a long time. That's not good enough. When? Get the photographs out. Bring me photographs when you were this age, this age, this age. Did you have any swelling then? We can help to piece together the missing bits if we've got evidence to help us. Thinking about, does it go down overnight? That's starting to make you think it's probably not a true lymphedema, because that means that there's probably excess fluid there, increased capillary filtration. Thinking about, have they had cellulitis in the past? Have any of the members of the family got swelling? Anybody else had the same problems? Anybody got the same shape as you? Oh yes, there's this, that and the other. It all helps us to build that picture as to what is going on. Calcium channel blocking medications, we talked about hypertension earlier, significantly important group of medication that seems to control patients really, really well. However, they all exacerbate lower limb conditions and cause red legs. If they can be changed for an alternative, if at all possible, then they should be. We appreciate that that's not always the case. But anything ending in a peen, we should be looking at getting changed if at all possible. Thinking about interviewing patients when we're asking them how long they've had their swelling, whether there's any family history, thinking about photographs. We also need to be thinking about the effect that the swelling is having on them. We thought about that with scar management in Annette's presentation. Again, swelling can be the same. If it's a head and neck patient after cancer with a very large facial swelling, submantle swelling, there's an awful lot we need to do to identify how much this is affecting them and how can we actually help with that. Referral on may be necessary. What factors affect their outcome to treatment? We talked earlier about those we can't compress with arterial insufficiency, but we do have to accept there are other conditions that we may not be able to achieve our end goals with and being realistic. Diagnostic tests, we talked about the Stemis test that you can do. The other tests that we would regularly refer for are lymphoscintigraphy, which is where we inject dye into the web spaces in between the digits of the upper limb or the lower limb, and then we use a gamma camera to image that, and it gives us function over time for how long it takes to be excreted through to the liver from the web spaces. It's invasive, it's radioactive, although that's only mild, so we have to choose carefully who we use, and it is only a function test. It won't tell us if there's areas of the lymphatics missing, but we do use it to aid in our diagnosis of certain patients. IG fluoroscopy is the new diagnostic tool and technique for lymphedema. It is using indocyanide green dye, which has been used in eyes for years, for any of you who've done ophthalmology, with specific cameras, and it's utilising that technology but for the lymphatics. It can show us anatomy, and the most surprising thing to come out of it to date is that it is showing us completely different drainage routes than we ever thought were there, and in the patients who've had lymph node removal, it's showing us that new pathways exist that again we didn't know were there. So we are learning all the time. Colour duplex Doppler ultrasound is significantly important as well. We've talked about ABPI earlier, and that's massively important to think about ruling out any acute causes of swelling, including DVT. Pitting is an interesting one. I used to work with a vascular surgeon that said that any edema would pit. It depended on how long you leant on it and how hard. And I suppose he was right in some instance, but Lympphedema won't pit, however hard you press on it. But it isn't a very clear diagnostic tool. So although some people will say, oh, I've done the pitting test, we tend to shy away from that because it is so subjective. One thing, really important thing to remember from your examination, make sure the patient takes their clothes off and shows you the whole area. What I find the biggest problem in our community teams is that we look below knee only. the leg ends at the knee. But it doesn't. But it certainly does for most of the colleagues that I work with. We don't look above that area. And when we did the lower limb test, looking in the hospital for wounds, again, nobody even thought of looking above the knee. When we were asking patients if we could look at their thighs, they were quite horrified because it was just a quick look below the knee generally for healthy heels or pressure area care. So ask them to strip off. If it's an arm swelling, we need to know, does it extend onto the body? Does it extend into the breast? If it's a leg swelling, does it extend into the groin, the subcutaneous, the pubic area? The gentleman you saw, the prostate gentleman, if he only rolled up his trouser leg to his knee, that would be hiding a massive problem underneath. So make sure that you see them to make a diagnosis. Looking at other examinations and things that we would look at, looking at the nails, looking at the skin, looking at the tissues, all of those things you do already below the knee, but make sure you also look above the knee. And thinking about assessment, we would agree that all patients should undergo a Ppi assessment, but in the lymphedema world, we put our hands straight up. I would think probably most of us, it's probably less than 3% of us that actually do carry out that, and yet 100% of our patients are in compression of some form or another. So we are probably the biggest culprits. But ABPI offers very little to me with large limbs. When I've got a calf that's over 1.5 meters in circumference, no ABPI test or cuff is going to be big enough or is going to give me an accurate reading, and I don't have 20 to 30 minutes to rest my patients before their appointment. So unfortunately, I put my hand up, the biggest culprit. Blood testing can be useful. Binatriuretic peptide testing, or BNP testing, is one of the most important blood tests that we do from our clinic, and it's a useful one for you guys to know about because it can rule out heart failure. So if a patient's got bilateral lower limb edema, which appears to be increasing, whatever you're doing doesn't seem to be doing anything, then BNP test, it's cheap and simple and available at any GP surgery, will actually rule out or indicate if there is any heart failure. And we've had a significant number of patients who've been able to move on with a good treatment protocol after being diagnosed with heart failure that we weren't aware of before. And often when patients have got swelling above the knee, I would say that is the first thing that we should be doing and screening for. Usual TFTs, LFTs, they can be useful. There can be edema caused by that. Anemia can cause swelling, so again, full blood count, and if there are any concerns regarding infection, CRP, ESR is useful. Swabbing, that's a whole interesting ball game. Microbiology and the guys that work with at the hospital think it's a complete waste of time. Other people won't not have it done. I don't know. I haven't got any conclusive ideas. I think it's probably one of those things depending on technique. Roland would like me to be quiet. Just to remember, we talked about patients with massive comorbidities earlier. One thing on top of another on top of another. Unfortunately, that's the same with chronic edema. It doesn't have to be one. We get lymphedema, so lipedema that over time has overloaded the lymphatics. We get crossover of these chronic swellings, and that makes it much, much harder to treat. So I think the important bit regarding this is trying to rule out anything that makes it an acute swelling, because therefore you know you are dealing with a true chronic edema. And at that point, that's when you can start to try and pull them into one of those categories to explain to the patient why they've got the swelling. We're all here because we agree with the model that's about involving and empowering patients. And if we can tell them why they've got the swelling, it's not fearful, it's not worrying, and they can then help themselves with our self-management techniques. We talked earlier about some of the new technologies coming in for compression that put patients in charge, and I think that is going to be the change that we might just see that will help to make people move forward without these slow, dripping, wet, leaky, large legs that we haven't been able to manage appropriately in the past. Thank you.